our cancer patients. So at this time, I'll just wait for Matthew to bring up the presentation, and then I'll start. So Matthew, I'll get you to go to the next slide. And so I'll just briefly start with our objectives today. So I will talk to you about who ODANO is. I'll give you a bit of background information about our group and organization, the regions that we currently are in, our referral process, why this role has become necessary, the benefits to the patient, the benefits to the center, and how we work together. And then I'll get you to change, Matthew. And then finally, we'll talk about the objectives, our objectives about challenges or our wish list, what we feel as navigators would be the best case scenario that would make our job easier and help our patients. And then I'll close off by having a few short case studies just to give you an example of what it is that we do on a day-to-day basis. So we can change. I'll just start off by giving you a brief description of what ODANO is. So we're a provincial organization of drug access navigators. We're founded to provide support, advocate for members, educate and share resources with existing and new members in order that we can maximize the appropriate funding for all our cancer patients. And then next we have the mission statement. So we worked at this quite a while, but we summarize it as every ODANO member has the resources and the knowledge to ensure that every oncology patient has access to the medication they need. So basically, we don't want somebody that's in Windsor to have a different outcome than the patient in Sudbury. We share our resources and to make sure that we can help every one of our patients the same way. Now I'll just give you a bit of background information in terms of our membership. We're currently over 50 members, anywhere from 50 to 75. We vary because there's 50 assigned members that specifically do drug access solely. And then we have a group of other navigators, but they have different roles. So they might be pharmacists/navigators or social workers/navigators. But somehow this role is intertwined into their job description. So we're mostly made up of pharmacy technicians, administrative assistants, social workers. There's a few RNs, and like I mentioned before, there's a few pharmacists in our group. I apologize. Just to give you a quick, we started this organization about 2007, 2008, and at the time I was one of the founding members, and we were less than 5 people in this group. So we've come a long way. We've grown, and we continue to grow. This is this slide here is just to give you a brief snippet of the cities that we are currently providing our services. Some of the smaller centers are, between 1 and 2 navigators, and some of the larger centers like Toronto and like Greater Toronto, obviously it's not uncommon to have 14 or between 15 and 20 sites that have navigators, and of those sites, then they have 2 or 3 navigators working full-time or part-time. Next, this role is kind of catching on in terms. It started off in Sudbury, and there's 1 or 2 navigators in Alberta. I had the opportunity to go to British Columbia about 2 years ago, and at the time there was 2 navigators that were put into place. And then Quebec, quite a few years ago, about 5 years ago, I did a lot of work in Quebec to get this role up and running. They were quick on the starting mark, but now they're planning their own conference. They have, I think up to 10 navigators, or 8 to 10 navigators in the province to help those patients. So it's really taken off, so it makes me quite happy. And then I believe that we have a couple in New Brunswick, Newfoundland, and then 1 in Nova Scotia. So as you can see, we're growing, and we seem to be growing, going off to the East Coast, and so more and more of our cancer patients are being helped out with this role. So I'll just define our role is in that who is referred to us is if a patient has no drug coverage, we will assist them with a Trillium drug application. And just to give you a bit of background for that is that it's a public health care plan, and everybody qualifies for this. It is income means tested, so it means the more net income you make, the higher your deductible is. It's approximately 4 to 5% of your household net income, and they divide that into quarters to make it more financially attractive for patients to pay. Another thing that we do a lot of is that we apply and track and renew the Ministry of Health Exceptional Access Program applications. We do an awful lot of this. A lot of these drugs are funded by the ministry, but they do require something like a private insurance, like a prior authorization. So if the patient fits criteria, then that is approved. And this is, like I said, for drugs. In the ministry, there's 3 categories of drugs. So there's general benefit drugs. That's just written and filled out as long as the patient has drug coverage with the ministry, or like Trillium or long-term care or temporary drug card or ODSP, then that's just a direct script at their pharmacy and they fill it. And then we have limited use drugs, and those drugs, as you know, then they're just limited use. We have to make sure that the patient qualifies for certain limited use the drugs, and then we go on to the exceptional access, like I've just said. And then lastly, we apply to the Special Access Program for Health Canada, and this is for drugs that have not received NOC, the Notice of Compliance, and they're not funded by the province. So we apply for special access, and then we find the money for the treatment. So sometimes it's given to us, or it's given to the patient by the company, or sometimes not. So we try and find funds accordingly. And then lastly, we investigate funding through private insurance. So we do an awful lot of 3-way calls with the insurance, the patient, and the company. The patient, the insurance company, and the navigator. And we fill out all of their prior approval authorization forms. Sometimes they require exceptions to the formulary, so we navigate that for them. And then renewals oftentimes are necessary for some high-costing medication. So they will approve, let's say for an example, Temidol. It's very expensive. So it's not unlike an insurance company to approve the use of this drug, but for 6 months, and then we have to provide proof or supporting documentation that this treatment is actually working. And if it is, like it usually is, because otherwise we would stop the treatment for the patient, then that's done. It's a bit of paperwork, but we do it in the background from the patient knowing, so that it's a seamless coverage process. And then, of course, we take care of appeals. Less and less, I think, personally, from my experience, they're not necessary. I've had good luck in getting drugs covered, but definitely it's not uncommon for us to have to put appeals and write letters to get a certain drug added to the formulary, or asking them to make exceptions. And then another thing that we do an awful lot is sometimes we have to use a combination of private, public, private and public plans to fully fund the drug. So this is for patients who have part insurance, so we have to max out the private insurance, then we switch them over to public, so we register them with Trillium, and then thirdly, we try and find money to cover that deductible for them, because for high-costing cancer treatments, as you know, it still leaves them with a big portion that is not paid for. So we do our best to try and find them money to cover that. And then we enroll patients with pharmaceutical companies all the time through patient assistance programs to investigate the programs that are available to help patients. So some companies, for example, would have a bridging supply. So if we submit an EAP to the Ministry of Health, but we have to wait anywhere from 2 to 4 weeks, and the patient and the physician want to start this treatment yesterday, then we will send a copy of the EAP to the manufacturer, or to the pharmaceutical company. They will review our application, and if they're confident that we will be approved, they will grant us bridging supply. So they will start the patient on treatment. When we receive our approval, then they switch over to that plan. And they're able to, of course, back bill and get what the bridging supply paid for. So this is how they do it. And some other companies offer compassionate drugs for our patients, and this is usually the case for medications that have not been approved. It's received an OC, but they're waiting for the funding approval to come into place into our province. So oftentimes they have a program that might help our patients between, the programs can run anywhere from a month to 6 months to a year, but that helps our patients. And now I'd like to talk to you just a bit about our primary role, the benefits to the patient. Our primary role here, I think, is that we're patient advocates. This is why we exist. This is what gets us out of bed in the morning. Our whole purpose for being is for the patient. So we put the patient first. And then we remove the financial burden from the patient. So one of the first things I say when I meet with a patient is saying, you deal with your cancer treatment, and I'll deal with the financial part. And when I run into a roadblock, or I've exhausted all my avenues, then I'll burden you with that. But otherwise, I have so many tricks up my sleeve that don't worry about it. So that tends to really put their mind at ease, and it reduces anxiety in the families and patients. And then we assist patients with access coverage. So like I said, we explore all possibilities. We leave no rock not turned. We try and do our due diligence to get all funding coverage available. And obviously we help our patients with their insurance forms. So any kind of paperwork that they're asked or that they require to get the drug funded, we handle all of that. And then we'll switch over to the benefits to the institution. So we're truly a centralized program. We offer one-stop shopping, and that referrals are made to us. It used to be in the past, it was a variety of people doing this job, so it was a real mishmash. We had pharmacists, we had primary care nurses, we had sometimes physicians. I think that a lot of patients went without or didn't get adequate funding for some of their treatments when this was available. So we've become the resident expert. This is all we do all day, is deal with these this drug coverage problem or process for the patients, and that we've become part of the treatment team. So if you look at my little diagram in the next part, we truly all work together. So, we work closely with social workers, with the pharmacist, very closely, the nurse, the physician, and then we're there, and somewhere in the middle, of course, is the patient, and we're all working for the greater cause. So that brings me to the next slide, which is how we work together. So the physician makes the referral to us, the drug access people, and then we are asked to investigate various treatment options. So it's not uncommon for the doctor to map out the treatment and say, this is treatment A, treatment B, treatment C. See what you can do. My preference is A, I'll go to B, or I'll go to C. And then, of course, the physician makes the final decision, but we are able to give a review of what's available. And then one thing that we try to keep in mind is that lines of therapy, with more and more of these drugs that are coming out, it's not uncommon to have 4 lines of therapy. But with the Ministry of Health, you can't give drug A before you give drug B, or vice versa. You have to give drug B first, they have to fail, and then they can have drug A. So the process is kind of complicated, but we keep that all in check, and then we give that summary to the physician. This sounds a little cumbersome, but we're used to dealing with these types of things, so it's given in real time, or there's not a big time lapse between the time of referral and the kind of feedback that we can give back to the patient. Sometimes it's right away, sometimes it's in a day or so, depending on what information is available to us. And then I'd like to talk to you a little bit about the issues or our wish list when it comes to the public payers, meaning the Ministry of Health, anything like that. We would like quicker processing time of our applications by the Trillium Drug Program. So it's a two-tier system in Ontario. So we need permission from the Ministry of Health to use the drug, and then we need to find the money for the drug. So we need to register our patients with Trillium, and that can take up to 6 weeks or more. So it causes delays in treatment, and it can affect treatment outcome in many times. So we try, and I'm constantly working with Trillium to try and expedite our request. And sometimes, oftentimes, it means that we draft up a letter of medical urgency. I draft it up. I get the physician to sign on it, saying it's very important that this patient receive this treatment. Sometimes it's a matter of life or death. The patient must start right away. So it's not uncommon for Trillium to approve me, and anywhere less than a week sometimes. But it's not uncommon for Trillium sometimes to drag their feet and take 6 to 8 weeks. So there are both examples out there, and not everybody has been able to fine-tune and get Trillium on board. So, and then quicker response time by the Ministry of Health, the Exceptional Access Program. Like I said earlier, sometimes we're able to get really quick results, and other times it can take more than 4 weeks. So the ideal outcome should be within, or that would be satisfactory, I guess, sorry, would be 1 to 2 weeks, and that's our goal. So we keep all of our EAPs. We have a hanging file system, and we keep them in there. We're always reviewing. But if we could get our answer within 1 or 2 weeks, that's acceptable for the physician and the patient. It seems like a long time sometimes for the patient to start, but it's the way that things work in Ontario. And then if we switch arms and we go to the private payer, the issues or wish list that we have there, I think I've listed 3, that the private payers deal directly with the DAN, with the navigators on behalf of the patient. So today most carriers will not speak to us without having the patient on the line. And that can be cumbersome because it can take anywhere from a few minutes to 30 minutes on hold, waiting for an agent to come. We would like us to be recognized as members of the patient healthcare team and as patient advocates. And then a dedicated contact for each individual company, the major players anyway. If we had a dedicated contact that would be assigned that we could deal with directly instead of speaking to somebody at a call center and a different person every time, that would be helpful. So we're working on that. There's currently a small group of us that have formed, a real group, and we're working with some professional people in the business and trying to set up meetings, with like Sun Life, Manulife, all the big players, and trying to work on these issues. And the second one would be to see quicker decisions. Currently, what we would like is 5 business days. But sometimes with some of these insurance companies, it can take a lot longer than that. It can take 7 to 10 days. It can take 2 weeks. Depending on companies, we have scenarios that we come up with. We see it all. Because these are cancer treatments, they can be a matter of life and death. So we really push. We're like hounds. We call often. And then our third and last issue that we put on our wish list is a dedicated managed contact to escalate issues if necessary. So meaning we want a manager or we want a supervisor that we can say, okay, we need to speak to you, person A, to expedite this. She needs to understand, or he needs to understand how important this is. because currently it's very difficult for us to be transferred to a supervisor by the call center representative. It doesn't seem to happen. So I'd like to close off. I'm just going to give you a quick little 3 examples of case studies before I hand off to Michele. So in this case study, we have, it'll be the next slide, Matthew. We have a newly diagnosed breast cancer patient, and he has private insurance. He or she will receive 8 cycles of adjuvant IV chemotherapy. So the patient requires supportive medications at a cost of $19,000 during the duration of her treatment. So the referral obviously is made to the drug access person. We investigate into her private plan. We find out great news, it's covered at 100%, but we also find out, that the plan has an annual maximum of $5,000. So that is not a good thing. That doesn't go very far in the world of oncology. So, and we also, but the patient does have a pay direct card, so that's good. They don't have to put out any kind of money beforehand. So that's adequate coverage, but it still leaves 1/3 of the cost of the medications that she will require. So things that we have to do, the next slide, is that we have to max out her private plan. We have to assist the patient with the Trillium application. We have to arrange to have her application expedited. And we transition from the private to Trillium, which is not an easy thing without causing delays, but we manage. And so adequate funding has been secured for all the medication required at little or no cost to the patient. So that's a good scenario. The second case study is a patient has been prescribed an oral chemotherapy treatment, and the cost is $4,000 a month. So the referral is made to us, and our plan of action is that we investigate private insurance, but she's covered at 100%. But the patient has, the clicker here is that the patient has a pay and submit plan. So $4,000 a month, not everybody has that. So this patient has no means to pay. So we will ask the insurance if they can make an exception and add this to the formulary because of the cost, if they can add this to pay direct instead of pay and submit. Sometimes we're approved, sometimes not. But in this particular case, the application was denied. So we contact the pharmaceutical company as a last resort to see if their patient assistance program will investigate what kind of programs are available to help the patients. Specifically, we'll see if they offer an agreement to pay. And what agreement to pay is that they'll pay the first month for the patient. The patient will get the receipt from the pharmacy, which will say it's been paid for, and so they submit it to the pharmacy, to their insurance company. They get the money back, and then they pay for the second one, the second treatment. And along the way, by the time the last treatment comes, then they take that money and then they pay the patient assistance program. So this is kind of used. This is used quite a bit to help our patients who don't have the means to pay for their treatment. So the patient can basically proceed with treatment as is. And quickly, thirdly, the third case study is that we have a patient with disease progression, and he or she is referred to us. The patient has private insurance, but the medication is not a benefit on his plan. So it's a very limited plan, or it's just they don't cover it. So we make an application to the insurance company for an exception to the formulary, but again, we are denied. So then this drug is not publicly funded, so that's another complication. It's not received, the funding approval hasn't been made for our province yet, so it's only covered for patients who have private insurance. So it's not in this case, and there's no other treatment option for this patient. So unfortunately, this is the end of the road in terms of oral chemo. Sometimes they can be prescribed, as a last resort, some IV chemo, which can provide a bit of relief, pain relief. but a lot of times it's the end of the road in terms of the doctor has maxed out everything in terms of treatment options, and it's not the best outcome that we have, but sometimes that's the case. So I know I've run a little bit late, so I want to just thank the Canadian Cancer Survivor Network for having us give a brief explanation of our world day-to-day. And now I'd like to hand off to Michele, who's a member and also has been touched personally by cancer. So she'll give you a bit of information about her journey and what that's been looking like. So thank you.
Thanks, Paulette. Hi, everyone. It's Michele MacDonald. I just want to start off by thanking Matthew and the Canadian Cancer Survivor Network for allowing me to share part of my personal journey with you today. So as Matthew said, my name is Michele MacDonald, and I am a drug access facilitator at the Juravinski Cancer Center. And I also sit on the board as treasurer for the Oncology Drug Access Navigators of Ontario, which is our Odano group. I have been a drug access navigator since 2008. I have worked in retail pharmacies as well as the last 7 or 8 years in the Cancer Center. I also was a teaching assistant at Mohawk for the Sterile IV Lab course, which is part of the pharmacy technician course. So I have had a little bit of dabbles in different areas of pharmacy. A little bit about myself quickly as well is I am a licensed member of the College of Pharmacists, and I am entitled to practice as a registered pharmacy technician. I am a member of the Ontario Pharmacists Association. I'm also registered with the Pharmacy Examining Board of Ontario, and again, treasurer for our Odano group. So my journey started back on November the 4th, 2013. The day before, on the Sunday, I had found a lump. I had suffered from cysts for quite a few years since I was a teenager, so I knew that this lump was a little bit different. So I called my family doctor. I got in the same day, went back to work. I had received a call to go back in and have another mammogram done. They were very concerned. They kept me. I had ultrasounds, and the radiologist was concerned to what he saw on the ultrasound. So I went back the following day, had a biopsy. So at that point, I kind of knew that the probability of me having breast cancer was very high. So I did, and I left there thinking, oh my God, how can this be happening to me? I work at a cancer center, and, you think of these things only happening to other people, but it does happen to you. So in the matter of a day, my life turned upside down. Instead of going to work, I ended up going to doctor's appointments, ultrasounds, x-rays, MRIs, biopsies, blood work, more doctor's appointments. And unfortunately, the day that I had the biopsy on a Wednesday, I was leaving for Cuba on the Friday. So at that point, I was wondering, should I go or should I stay? And the radiologist assured me that it would be 7 to 14 days before I received the results of the biopsy. Even though they were going to rush it for me, it would still be at least 7 days. So they said, you should probably go. Maybe it'll take your mind off things. And I did. I went on my holiday. It was a little hard to enjoy myself, but it did definitely take my mind off of things for at least a few weeks. The concern I had was I was coming home late on the Friday evening, and I didn't want to have to wait another full weekend. So my doctor promised me that she would leave me a very detailed message on my answering machine. As I assured her, I had an answering machine that only I had the code to retrieve the message. So when I got home, I had the message that it was definitely positive for cancer. So because I work at the Cancer Center and you meet such a wide variety of patients, the most important thing that came to my mind was I was not going to be negative. I was going to be positive. So I came up with a few little words for cancer, to have courage and be courageous, and advocate for yourself, and don't give up, celebrate your life, be enthusiastic, and hopefully the research that is being done constantly, especially in the breast cancer field, will help will help you get through things with a positive outcome. So my journey consists of the last year and a half being a bit of a blur. I do remember thinking, wow, well, I work in a cancer center, so this is going to be a lot easier for me than I expected. But, I know what's going to happen and, everything will be fine. But I was totally wrong. I actually had no idea what I was in for. And until you actually are on that other side of the fence, so to speak, we see patients when they're needing drug coverage and drugs, but you don't really see what happens before and after. So a lot of that process I actually didn't know, and I wasn't aware of coming and going from the cancer center. And before I lost my hair, nobody knew that I was actually coming for chemo because I still looked okay. But as the process went along and people did see, then they got to know that yes, I was going through a cancer journey myself. So again, I got my biopsy results positive for invasive ductal carcinoma. I was actually very lucky, and I would hope it would be like this for every patient, but I had an appointment right away with a surgical oncologist who I do work with in clinic, who was wonderful. I did ask for a bilateral mastectomy, and she definitely had no problem with that. It was a little bit more than I expected. I was in the hospital for, I believe it was 4 days, very painful, and I don't think you can prepare for the emotional journey that comes after that. So then, of course, I had a lymph node that came back positive for very microscopic amounts of cancer cells. So I unfortunately had to go through the 4 months of chemotherapy. Sorry, I am corrected. I had 3 out of the 6 lymph nodes came back with cells. And at first, the only thing I could think about was, oh my gosh, I'm going to lose my hair. I had beautiful long red hair, and that was the first thing that came to my mind, instead of worrying about, I'm going to have all these toxic drugs running through my body and what's going to happen. So I eventually got to the point where that was the last of my concerns. My health was the first and foremost concern. So I did have an axillary node dissection about a month after I finished my chemotherapy, which is a procedure, and they go back in underneath your arm and they take out what's called level 2 lymph nodes. So they all came back negative, which was a huge relief. So that could mean either there could have been a little bit of cancer cells in the nodes, but the chemotherapy took care of it, or the cancer cells didn't pass any further through the lymph node system. So I finally felt that after about a year, I at least had some good news for a change. After that came back, the radiation oncologist kind of, left it up to me. He said I really technically didn't need the radiation, but he would certainly go ahead if I felt that I would like to do that anyways. So after you've gone through chemotherapy, I thought I may as well take every little bit of help I can get. If it's another 3 to 5% on top, that it's not going to come back, I'm going to go ahead and do it. So I went ahead. I had radiation every day for 6 weeks, and I absolutely knew nothing about radiation. I thought this is going to be a piece of cake. But it was actually more mentally and physically draining than the chemotherapy was. You didn't go through a day where you didn't have to sleep for a few hours in the afternoon, and then by 7 o'clock at night it hits you like a ton of bricks. You are just exhausted to the point where you can't even go grocery shopping for half an hour because you feel like you just need to sit and hold on to something. So I definitely wasn't prepared for that. So during my journey, I also was seeing the plastic surgeon who actually put chest expanders in at the same time as my mastectomy so that I could go through the expansion process, which is part of the reconstruction. This process includes going to see him every 2 weeks, and they inject saline into your chest expanders, and it gently expands the remaining skin you have in the breast area in order to make room for your implants. This, for me, unfortunately, didn't go well either. The right side, which was the radiated side, the tissue damage was, I guess, a little bit more severe, and my tissue wouldn't expand. So due to that, we ended up making a decision that I had to undergo a third surgery, which was called a latissimus dorsi flap surgery. This entailed removing some tissue, muscle, and skin from my back, and then they added it onto the front. They leave the actual artery intact, and they actually just kind of pull the tissue, muscle, and that through and up, and then they sew it in to the front of your breast area. This was by far, I think, the greatest challenge I had since the day I was diagnosed. I was in a lot of pain, and I came home with 3 drains, one in the front, one underneath my arm, and one in my back. I was cut from the middle of my chest right around to the middle of my back. They did send me home with a daycare nurse or a home care nurse that would come every day to check for infection and check the drains and that sort of thing as well. It was excruciatingly painful. I don't think I was prepared. I thought, you know, it's not going to be as worse as the bilateral mastectomy, but it actually was a little bit worse. So that was a little bit of a challenging process as well. So 3 weeks after I had completed that surgery, I returned to see the plastic surgeon. He was very happy with the surgery. Everything went really well. And then he was able to restart the expansion process. So that meant having the saline injected back into the chest expanders. And then now I was relieved to know the skin stretched out perfect. And once I get to the size that I wish to be, then we'll stop the injections. At that point, you will sit at that size with the chest expander still in for 2 to 3 months. And at that point, they can go back in, take out the chest expanders, and put the implants back in. So I'm hoping to have that done by July or August, and then hopefully be back to work by September, October. And that will actually be almost 2 full years since I've been off work. So me working as a drug access facilitator, one of my first concerns was, what is going to be the drug costs for me? I have insurance, my husband has insurance, but you don't know what's covered, what's not covered. So the first thing I did was, am I going to need prior approval forms? Like Paulette said, beginning, it's about $19,000 to $20,000 just for the drugs for the course of the chemotherapy. So I'm thinking, oh my God, what if I don't have full coverage? So me being a drug access facilitator, I got on the phone and called both the insurance companies right away. I just wanted to make sure everything was going to work out before I started. And I was extremely lucky that I had about 80% coverage, but my husband's coverage was 100%. He didn't have any prior authorization forms that they needed done, and we had no co-pays. So I counted my very blessings that this would not be a worry. So when the drug treatment part was completed, I had kept all of my receipts. Even though I didn't pay anything, I did add up the total amount of the prescription cost, and I was completely shocked. Drug access navigators are definitely a necessity, as these costs for drugs, for chemotherapy or other cancer treatments is just incredibly high. So what have I learned from my journey as a drug access navigator going through the system herself? I've learned that breast cancer is the second leading cause of death in Canada for women. Although breast cancer death rates have gone down in every age group, this reflects the impact of better screening and better treatment options. Nobody is safe from this disease. If it can happen to me, it can happen to you. Cancer does not discriminate. So working as a drug access facilitator and going through cancer myself, I think when I return to work, it will allow me to do my job better. I have always tried to look normal going through this whole process. I always had makeup on, I always dressed nice, and I always had a smile on my face. Even through the lowest day, you know, when I had no energy, I was sick, I was bald, I still went out, I put my makeup on, and I got dressed. Even though I looked and felt terrible, it didn't mean that I was fine. So when I go to work and I see people that, you know, they look like they need a smile, I think I'll have a little bit more patience because you don't know what's going on with them in their personal lives. I was extremely lucky that I worked in the cancer system. My coworkers were awesome. It was very heartwarming experience to know how much I was actually cared for. Not one chemo session went by where I didn't have somebody coming in to cheer me up. Do I need a tea? Can I get you anything? Do you want a magazine? How are you doing? I had the best support, and working in that environment that we do, it certainly made the journey go a little bit easier for me, but it is still overwhelming. So my final thoughts, I came from a pretty close family, but it definitely made us closer as a whole, and it really makes you enjoy every minute you have. Unfortunately, before I was diagnosed with my breast cancer, I had a nephew who was diagnosed with leukemia at 2 weeks old. Unfortunately, he had passed away 3 weeks before his first birthday. I have also had other family members deal with cancer as well, but between my nephew and then myself, it's been, like I said, you need to enjoy every minute of life you have. You only have one life to live. And ask for help. That is the biggest thing I can stress. Don't wait for people to offer. Most people will say, if there's anything I can do for you, you let me know. But don't wait for people to offer. If you need something, ask. Other people can come and cook for you, clean for you, do your laundry, errands, banking, but you are the only person that can fight your cancer. And I also learned that I can actually put myself first. And I can honestly say this is the first time in my life that I have learned to do this. You have to take care of yourself. You need to focus on the present and use your energy to focus on your treatment and getting better. Dwelling on what you can't change will only cause you to lose the ability to cope. You can sit and cry or feel sorry for yourself, or you can choose to be strong and positive. Trust me, being strong and positive will make you stronger, more positive, and change your outlook on life. In some ways, cancer was a good thing for me. I am a perfectionist who now has learned to slow down, relax, and enjoy life. Thank you.
Okay, thanks to both of you, to Paulette for explaining what all this is about, and for Michele for giving us more of a personal touch on how it all works. Now we will turn it over to questions. So if anybody on the call has questions, you're more than welcome to type them down in the questions bar at the bottom of the GoToWebinar screen. I'm sure either if you have anything for Paulette or anything for Michele, I'm sure both of them would be happy to answer any questions that you have. So don't hesitate. If you have anything that you want to know or anything you want clarified, definitely let them know, and we can do our best between the three of us to make sure it gets answered.
Kathy, I was just saying, perhaps I could send you my email, and if and Michele could do the same. And if somebody on the road has something for us, they can definitely email us, and we can communicate with them that way.
Yeah, absolutely. And for anyone, we do record these, so if there's anybody who's watching on the recorded version who has a question that comes to mind, I'll leave the emails of both Michele and Paulette down below, and you can contact them through there. We have a question here from Marilyn, and she asks, are the 50 members specific drug navigators? Are they employed by cancer centers? I don't know who wants to answer that, but
I can. So there's over 50, and they're for all cancer drugs. And sorry, what the question? Oh, it's not just cancer centers. It's for any kind of center or hospital that offers chemotherapy. So let's say I live up north. I live in Sudbury. So we have about 15 outreach sites where we give chemotherapy. So the patient is first seen by us here in Sudbury, but it's not likely for them to receive their chemotherapy in their community. So I work along with their retail pharmacist or with the patient on the telephone and navigate the process that way. So hopefully that answers your question.
Yeah, and actually in Hamilton as well, we have a small hospital just outside of Hamilton that they do a little bit of chemotherapy, cancer treatment, but they don't have a drug access, and they know they can call us if they have any problems with a patient or drug, and we help them out at any way we possibly can.
Okay, thanks. That's great. Still waiting for any other questions to maybe come in. Marilyn's asking again a follow-up question. Does each cancer center in Ontario have a navigator?
Unfortunately, no, but we are growing in numbers, and you're seeing members popping up every month in various centers. So there's still education on our part. We're constantly being asked, many of us, just to go in different centers and explain what it is that we do. And the problem that they have right now is the financial responsibility of paying for this role, but we're able to identify the pros and cons or the benefits to the patient and the center. And so, like I said, many of these centers and hospitals are putting in these drug navigators, and it's growing all the time.
Right. Also, Paulette, like you were saying, at our cancer center, we have we're a fairly large cancer center where I work at the Juravinski, and the physicians in our center, they always say drug access navigators used to be a luxury to have, but now it's actually a necessity.
Absolutely. The process has become so complex for patients that gone are the days that they can get a prescription and go to the pharmacy and get it filled.
Yeah,
there's one more question that says, is there a list of where DANs can be? We're very happy to say that our website for odano.ca is up. It's being worked on, and we're hoping by the end of May it's fully operational, and there'll be a component within that website that will list all the navigators if they consent, which hospital has them, and if there's somebody close by, like Michelle's saying, if they have them in Hamilton but they don't have them in the neighboring town, can they access her services just in terms of input? But we're very happy to report that this will be added to our website and also give a description of what we do and how we can help patients and different articles for patients and things like that. So it's been a long time in the works, but we're very happy to finally see the website come to fruition. So look for that towards the end of May. You can actually check it out right now, www.odano.ca, and we're quite pleased.
Okay, we have a couple more questions here, kind of more national focused things. So Marilyn's asking if it's going to include any national information or if it'll just be Ontario, and Mary Beth is asking if there's anyone in Calgary.
Initially I thought there was, and there currently, as far as I know, and I was dealing with some of the pharmaceutical companies. I work closely with some of them, and they're the ones that supplied this list. And so I think there's a lot of discussion happening regarding getting one in Calgary, but currently I don't believe that there is. And I think one province at a time is definitely our goal, is to see this in all provinces and to see it on a national level, but we're inching our way province by province to see this through. So given time, I think this will be very big. And another thing is that when we're asked to present, there's a lot of interest in various sites like heart, nephrology. It's not just cancer that this affects. So there's a lot of interest. For example, here at the Cancer Treatment Center or the Health Sciences North, there's a huge push to get this position. Specifically, we're looking at nephrology. because currently I'm doing some work for them, but there is a big gap. So I think it's being looked at, and it's just a matter of working out all the details and the funding.
Okay, so Mary Beth says thanks. That's good. If there are any other questions, we'll give it maybe a few more seconds here. But if oh, here we go. We got something from Sandra. She's saying, I'm in New Brunswick. A new role for our hospital would be great to get some information on. We can get some support for navigators in the province. Would be great to get some information. So I just have to read this again to get exactly what she's asking out of here.
I'm happy to say that a small group of us a few years ago we developed a resource guide, a drug access, a navigator book, and a support guide that we'd be happy to share. And then we do have some job descriptions, but Michelle or I or anybody, we'd be happy to share whatever information that we have to help this along. Absolutely.
Yeah, definitely.
Yeah, so I think what I can do is maybe if the two of you are all right with it, in our follow-up email tomorrow, we could send out your contact information to all the people who are here today if they have any further questions and whatnot.
Yeah, that'd be happy. Well, you have my email actually, Matthew, so
yeah.
Definitely we share that with the group.
Okay.
And we'd be happy to help them out.
Okay, perfect. That sounds great. Finally, Janet here's asking, is there the possibility of forming a Canadian Drug Access Navigators Association? And I know you've already kind of talked about this, but if you want to maybe speak to it again.
Sorry, what is the question?
Canadian Drug Access. She's asking if there's a possibility of forming a Canadian Drug Access Navigator Association.
I think there definitely is. You're seeing it more and more as the role picks up in various provinces. We hold a fall conference, and we're looking at expanding other provinces, and they can come to our conference, because we usually, it's not specific to drugs, but it's problems that come up, or information session regarding different sites that we deal a lot with. So there is a shift that's happening currently to have people from, Quebec or Nova Scotia, Alberta, definitely put the invitation out that if they do want to attend our conference, that they can. And this usually takes place the last week of October every year on a Thursday. And I'm soon to send out a reserve this date to everybody. So that's definitely in the works.
All right, well, that sounds great. I mean, as soon as you send out information on that, Paulette, I'm sure we'll put that up on our website, on our survivornet.ca website as well, and let people know about that. So if there are no other questions, I'll just do a little outro, and I'll keep an eye on the questions to see if anything else comes in. But I just want to thank both of you for coming on again today. It's been a pleasure. I think a lot of people have learned a lot of new things here today. So we definitely appreciate both of you coming on and taking time out of your day to do this with us today. Yeah, you're very welcome. So yeah, we'll be sending out a follow-up email tomorrow where we'll have contact information for both Michelle and Paulette in there. If there's any kind of follow-up that people want to do with them, if you want more information for them, we'll include their contact information in that. But other than that, everybody, just want to remind you again that we will be sending out more information on our upcoming webinars in June. So be sure to stay tuned to all of our social channels and to our e-letter for that. But I think that's all we'll say for today, and we'll see you all next time. So we'll sign off now.
Thank you. Thank you very much for the opportunity. Are we done, Matthew? Or should we stay on?
I know, I was wondering.